round cell tumors, epithelioid, spindle cell, myxoid, adipocytic, and pleomorphic. Round cell tumors. Now, what we see in the child? Now it comes the interactive session. What do we find in this child? We find that the patient has been incised thinking that the tumor is over the skin. But when you saw the patient, the tumor, this is the uvula, this is the buccal area, this is where the tumor is there. So if we did an FNAC from this, these are rounded cells. So child arising from muscles, a round cell tumors with scanty cytoplasm, and then almost the whole cell is covered by large nucleus. And what is this type of malignant cells? The history itself tells that it is possibly a rhabdomyosarcoma. These clear cell changes are seen in rhabdomyosarcoma. Don't think that it is an Ewing's, because if you see in rhabdomyosarcoma, these vacuoles appear. But basically we know that it is arising from the muscles. So it is not an extraskeletal Ewing's. Possibly first diagnosis will be rhabdomyosarcoma because it is arising from muscles. And see the cell block, how beautiful it comes out where you show the mitotic figures. See the chromatin, see that all these things come out in a very beautiful cell block. We usually do not do cell block because we do not get adequate material. The best possible way is to put the needle in the tumor, do the suction, do not take out the needle, right? Make the suction, take out the syringe. And in the syringe you will get some material that push it and make some slides. Do 2 to 3 areas from the same place without traumatizing the patient and making the patient bleeding. Change the site, take out the material, and then make slides. So we get plenty adequate material not only for cytology but for cell block. And if we do muscle actin positive, desmin and myogenin positive, this is cell block on the cell block, and this is diagnosis is embryonal rhabdomyosarcoma classical. Another child. See, the tumor is over in the oral cavity, but the patient has this ridge obliterated swelling in the face. Then where is the tumor? Tumor is, we find in the maxillary sinus, infiltrating orbit, base of skull is involved, destruction of bone, and the large tumor, which we cannot see by the clinically. Radiology tells that it's a massive tumor which is infiltrated the base of skull by destruction of the base, infiltrated the brain, and this is the cell. See, these cells perplexed us. What is this cell? Highly pleomorphic. Is it a carcinoma? Tumor giant cells are there. Cells are highly pleomorphic. What is arising from the muscles which is infiltrating the maxilla, going up to the skull and infiltrating the brain? We actually could not diagnose this case thinking to be possibly a high-grade sarcoma, high-grade anaplastic carcinoma. All we have proved, even if some tool diagnosis give ALCL, anaplastic large cell lymphomas also. So all these diagnoses came from this. Listen, we can see these are the cells. High mitotic figure, tumor giant cells are there. So we did a cell block. See how beautiful the cell block comes. What we see in cytology, it comes in the cell block itself. And muscle actin is positive, desmin positive, myogenin is scattered. And this diagnosis is the embryonal rhabdomyosarcoma anaplastic type. So we must be aware that embryonal rhabdomyosarcoma anaplastic type occurs. Now let us see what are the types of embryonal rhabdomyosarcoma. This is classical that I have shown. This is the anaplastic type. We think it possibly of high-grade carcinoma. This is solid variant which looks like a lymphoma. And this is spindle cell variant which looks like a leiomyosarcoma or other sarcoma. But we have to take help in these cases. I see, and the origin. Origin is very important, whether from muscles. This is the clinical part and radiological part. Origin, clinical picture is very important. So this is another patient where he finds a facial palsy. But here we find that there is a plug in the ear, and then we did an FNAC, just like facial palsy. Is the facial nerve involved? And see the tumor, large tumor infiltrating the orbit. Whole maxilla is almost involved. And these are the cells. The cells itself tell the characteristics. What we find? Connective tissue strands. Cells attached to the connective tissue strands. Cells are dispersed. Cells are free floating. See, beautiful connective tissue strands. The cells are attached, free floating. All round cell tumors. Large, the tumor, almost the whole cell is occupied by the nucleus. And see, this is the high power. This is the connective tissue strands, and these are the cells. Large cells occupying almost whole of the cytoplasm. And this is also positive. And cell block, see the beautiful cell block which I have seen in cytology. It comes in the cell block, and this myogenin is positive. Diagnosis is alveolar rhabdomyosarcoma, classical. Now coming to the next tumor, this is a child, came with a swelling in the parotid region. The surgeon thought that is a salivary gland tumor, but the patient is complaining pain in the temporal region. This is the area the patient is complaining pain. But when he did a CT, we find a devastating tumor. Where is the tumor located? See, it is arising 12 years, male child, arising, bone is destroyed, is a pterygoid muscle tumor. Median and lateral pterygoid muscles are involved. This is the large tumor, and this is the normal bone. This bone is totally destroyed by the huge tumor. And see, these are the cells. What is these cells? Wreath-like nuclei. Wreath-like nuclei is very classical of a soft tissue tumor. Also, wreath-like nuclei is found another where you find clear cell sarcoma of tendon sheath, where there also we can find wreath-like nuclei. But this is not from tendon sheath, that is arising from, and this is myogenin is strongly positive in this case. The diagnosis is alveolar rhabdomyosarcoma, solid variant. So these are the nuclei which produces wreath-like nuclei arising from the muscular origin, and is a huge tumor which is occupying the maxilla. So now, if we do not find the connective tissue strands, if we cannot label it whether it's alveolar or embryonal, what to do then? Because embryonal rhabdomyosarcoma has a good prognosis compared to alveolar. So for this we have to do FISH, because we cannot tell that whether it's embryonal. Sometimes myogenin stains strongly with alveolar, but not always. And interpretation differs from one person to other. Some will tell it is very strong positive, some tell it's not so strong positive. So they differ, but then we have to do a FISH. FISH means PAX3 FOX01 fusion gene, or PAX3 with PAX7 with FOXO1 gene. This fusion we have to study to give a classical. But at least we can diagnose it as a rhabdomyosarcoma. If we connective tissue strands are separating, we can possibly go for alveolar, do myogenin. If there is not, then if it is doubtful, then we can go for FISH. This is another tumor. We find again a facial palsy-like syndrome. And this is the tumor. See that it's covered by necrotic slough. And when biopsy was taken, only necrotic slough came out. But when you put the needle, we got plenty of material. And see, this is the area of the tumor, covered by necrotic slough. Little bit of bone is destroyed, or basically, but see, this is the normal ear, covered with air, and this is covered with solid whitish tumor. And when he did an FNAC, what do we find? Please, the PG students are there, what we see in this slide, what we see? What is this? Tadpole cell. Where do we find? Rhabdomyoblast, right? The cells, see, large cells, eccentric type of nucleus. The whole, it is a round cell tumor with rhabdomyoblastic differentiation. And see, this is the biopsy. What we find in the biopsy? We find heterogeneous, that is myxoid areas. This is a clear zone separating the epithelial and the deep cellular areas deep beneath. And this is the heterogeneous myxoid areas. And if we see this layer, what is this? Is the cambium layer. So this is the cambium layer where there is acellular areas just beneath the epidermis, followed by highly cellular areas. If we find cambium layer with this myxoid in the background, with this type of cells, what will you give your diagnosis? What will be the diagnosis then? It is definitely a muscle tumor. And see the cells on histology, this eccentric type, small cell, spindle cells and round cells mixed. This is desmin positive, myogenin positive diagnosis, sarcoma botrytis. Where sarcoma botrytis occur? Usually in the genitalia, in the bladder, but it also occurs in the ear, in the nose. It is a grape-like structure. Prognosis is good compared to other type of soft tissue rhabdomyosarcomas. So this is the tumor. We find that tadpole cell, we have seen cambium layer, we have seen Luke's myxoid stroma, we have seen hypercellular areas we have seen, and this is usually in the age of 4. This is a variant of embryonal rhabdomyosarcoma. And if we look at the morphology, all the morphology were present in the cells as well as in the cell blocks and in the histology. Now, it is the characteristic difference between a soft tissue sarcoma and carcinoma. What is the clinical difference? Can anyone tell? Carcinoma involves the epithelial part. So usually they present with an ulcerated area, isn't it? The superficial area is lost. This is an ulcerated area. But in soft tissue tumor, it's a deeper part, lobulated structure, intact mucosa. So these are the areas where we find the soft tissue tumor. Soft tissue tumor usually do not infiltrate the cutaneous areas and do not produce the ulceration that we find in carcinomas. So you see a lobulated mass in the oral cavity. And these are the cells. The cells tell the diagnosis. What are the cells? Rounded cells, fatty. Isn't it? The cells are filled with vacuoles. So, and these, what are these? Arborization of the capillaries. And some cells are epithelioid, some spindle cells along with these fat cells are mixed together. So these are the cells. We can see hardly any pleomorphism. Rounded cells. And only one stain can do Weil-Rado. So Weil-Rado is positive. So this is the histology, same thing that we find in the cytology, and diagnosis is given as round cell liposarcoma, oblique myxoid liposarcoma. It is one of the variant or round cell / myxoid liposarcoma. Now this is the case which I don't think I will get any more in my life. This is created a lot of interest, lot of problems, because we find multiple incisions have been given, thinking that it's, and the TrueCut biopsy, thinking that is a breast tumor. See the engorged area of the breast, nipple retraction, very classical of carcinoma of breast, but is it really a carcinoma of breast? So see the close-up view. See, this is the large bulky tumor present, stretching the skin, but no ulceration and the nipple retraction. Multiple areas they have taken a small incisional biopsy, but failed to take adequate tissue. And see what you find. It is a posterior mediastinal involved, anterior mediastinal involved, rib destroyed, breast is involved. So anterior mediastinum, posterior mediastinum, ribs, and all this, and this is the CT guided FNAC, and we have done also FNAC from the breast mass. So multiple areas we have done FNAC. What is this tumor? Where is the origin? Is it from breast? Is it from mediastinum? Is it from both, or infiltrating one another? And on FNAC we found these type of cells, round cells, compact, some closely adherent, some discrete, and these connective tissue strands like areas are intersecting. See, so much yield we can get in FNAC. And we cannot tell the report that's inadequate material. No, we get adequate material. We get adequate material, provided we put the needle in proper site, provided we know the radiological picture. Don't jump immediately on the patient and do the FNAC. So this is the cells that we got, and this is the histology. What is this? Desmoplastic stroma, cells adherent. I'm giving the clue. Any idea about the desmoplastic stroma? Cells attached to the desmoplastic stroma, some are free, but if it occurs in the abdomen, then what will you give the diagnosis? Same type of cells in the abdomen, in a middle-aged male or female, wherever it is there, then what will be the diagnosis? But it is an unusual location in the mediastinum and the breast. And see, this is the tumor, round cell sarcoma, right? And all the epithelial markers is positive, muscle markers is positive, neural markers is positive. Any clue, any diagnosis, any thinking? All three markers are positive. So this is the tumor, and this is CK positive, Desmin positive, and NAC is positive. Embedded within desmoplastic stroma, nest of small round cells expressing multidirectional phenotype with epithelial, myogenic, and neural marker differentiation clinches the diagnosis of anyone from the audience, from the PGT? Yes? Desmoplastic small round cell tumor, exactly, it's very good. It is a classical appearance of desmoplastic small round cell tumor. And see, not only that, we have followed that the patient was resected with the tumor. You can see these are the area of ribs. This is the bone and this is the soft tissue. And these are the streaming of cells. This is the desmoplastic stroma. So this is important. We have taken the gross specimens also along with the FNAC and the histology. This is where we feel satisfied. What we have done has fulfilled our dream, because this is a very, very rare tumor of desmoplastic small round cell tumor infiltrating breast, mediastinum, primary site, we don't know. And this is WT1 C-terminal positive, N-terminal negative. Diagnosis is desmoplastic small round cell tumor of mediastinum and chest wall infiltrating breast. Hallmark is Ewing's sarcoma, RNA binding protein 1, WT1 gene fusion, and which causes the cell proliferation by PTG